focuses on integrating screening services for cervical cancer, for cervical in HIV clinics, and generating evidence to support sustainability and scaling up of services using implementation science research approach. So you all see that from this resume is the best person to handle this presentation. So Dr. Mugisha, I warmly welcome you to start your presentation. Thank you so much.
Thank you very much, Chair. Yes, I was waiting for my slides to be shown. Thank you for inviting me to give this presentation. I will try to keep within the allotted time. Is it 30 minutes? This program is very generous with time, but I'll try to be brief because, as you can imagine, talking about the National Cancer Control Plan cannot be done in a very short time, especially when you're talking to people who might be hearing it for the first time. When you've heard it over and over again, it's easy to rush, but when you're hearing it for the first time, it's only fair to allow you to appreciate. Yes. Now, on the introduction, what you didn't add, I am a married man with 2 children, and we had a baby girl on 15th this month, so I'm a sekaware, not sleeping enough. So if you see me dozing, don't think that this man is not serious. But also I have an appointment to see a doctor in the afternoon, so I will beg that if I go away unceremoniously, don't say this guy is not well behaved. Just know I'm trying to honor my commitments on the other side. So the Uganda National Cancer Control Plan. This is just for your information that even though Uganda has been at the forefront of fighting cancer, we haven't had any organized strategic approach to dealing with cancer as a country. Sometimes it surprises people when you mention that, because we have one of the oldest population cancer registries on the continent, the Kampala Cancer Registry. Even the Uganda Cancer Institute was established in 1967, so it's well over 50 years old. But that doesn't mean that we have had an organized, arrangement of dealing with the cancer problems. So this is the first National Cancer Control Plan for Uganda. And before I go further, is that we've taken quite some time writing it. I guess because of that history, but let's just walk through it so that you're able to appreciate what it contains and also to appreciate where we are at this point. Because I can tell you that if you're Palliative Care Association members, definitely that this ought to be one of your core interests. Yes, because one of the consumers of palliative care services are cancer patients. I know there are many other categories of patients, but cancer patients are some of really our key targets as palliative care providers. Yes. So the Uganda National Cancer Control Plan that we are writing now, and I will be letting you know how far we've reached. It's supposed to be for 2024, 2025 to 2020. That's supposed to be 29-30. 2029-2030. And just to remind you that we've been advised to make sure we align this with the other national, strategic documents. Next slide. I might have to cross there and control my own slides, because then I will move faster. Yes, I think that will be better, because some things we don't have to go through them in detail. Thank you again. So that's the outline, and I don't think we need to go through the outline that much since we are going to go through it anyway, eventually. But as a PhD fellow, I have been taught to, organize my presentations that way, because sometimes there are marks for each slide. So what is the National Cancer Control Plan? This is for our knowledge, as I want to imagine that all of us hear English. Kindly, if you don't hear English, just put up your hand. I will mix some Uganda. I'm thinking that Palliative Care Association has people who don't speak English. Don't you? If we don't, we need to have them. So a National Cancer Control Plan is a strategic plan that is based on the country's cancer disease burden, but also the cancer risk factor burden, and also the resources available to implement the plan in the context of its culture and its healthcare system. Now, this definition is by the UICC. UICC, the International Union for Cancer Control, which is a global umbrella for cancer control. And the things to note here for you is that the plan has to be based on our disease burden, the cancer disease burden, but also it has to be based on our cancer risk factor burden, because when we are controlling cancer, we are also including preventing cancer. So it has to be based on the risk factor burden as well, but also we have to keep in mind the resources we have to implement it, and also the context of our culture and our healthcare system. Yes?
There are more people online than us who can't see the slide. I don't know.
Make the disease not happen only. We also mean things that we do to detect the disease earlier. And many people, usually they make an error of thinking that when we talk about prevention, we are talking about avoiding. No. When it comes to disease, we are also talking about early detection. You understand what I mean? And that we call secondary prevention. So for cancer control, we talk about prevention, early detection, diagnosis and treatment, palliative care, and survivorship. Now that is the cancer control continuum. You prevent, but you make sure you diagnose early, you treat properly, you provide all the care necessary, and when you survive, you support them to live positively after surviving cancer. But under each of these, which we call actually pillars, there are goals, objectives, and strategies. But what is unique about our National Cancer Control Plan is that we have a chapter on special interest groups. This is now important for you. It's really information that is unique about our plan compared to the other plans. We have a chapter on special interest groups, and for the first edition of the plan, we've chosen to focus on people living with albinism, people living with HIV and AIDS, and refugees. Now there are other special groups, but we chose these three as our starting point. It doesn't mean they are more important than others, but we had strong reasons to choose these three. And then we also have a chapter on cancer control in children. An element is left out in many other cancer control plans. And those of you who have looked at cancer data, most of the cancer data actually does not include cancer data on children, unfortunately. But fortunately for Uganda is that actually the Uganda Cancer Institute, or the treatment of cancer in Uganda, stunted with cancers in children. Because Bucket's lymphoma was the reason Uganda Cancer Institute was established in the first place. So we want to make sure that we keep fighting cancers in children at the forefront of our efforts. Because for me, as Dr. Mrisha, I think that's where we have the best gains for our investment, when it comes to dealing with cancer. On the next slide, now these are the target outcomes. We are not going to dwell too much on them, but usually the target, the aim of implementing the National Cancer Control Plan is to reduce the cancer risk. Remember, we talked about the cancer risk burden. Is to reduce the cancer risk, but also detect cancers earlier and diagnose them earlier. And you need to know that at the Uganda Cancer Institute, the biggest problem we have is cancers presenting late. So one of our aims, the outcomes, is really to detect cancers earlier. And then also to provide timely and better treatment and have better survival. Now, many of us who have dealt with cancer patients know that actually many cancers are treatable, many cancers are curable, many cancers can be controlled, even when people are already suffering from them. But we also want to make sure we improve palliative care. We also want to make sure we improve the quality of life. We don't want people with cancer to have poor quality of life. And of course, we had to align this with the Ministry of Health, vision of overall improvement in the population health will be the core of implementing the National Cancer Control Plan. Now, this is just a snapshot of our disease burden. In the year 2020, we had 34,008 new cancer cases. These were people who were diagnosed for the first time with cancer. 34,008 people. And we lost 22,992 to cancer. Now, if you do the mathematics there, you can see the people who died. You can see the proportion of those who are diagnosed with cancer. It doesn't mean that the people who are diagnosed then eventually died. No. The number who died in that year and the number who were diagnosed that year. But that gives us, a rough idea of how bad, the burden is in terms of causing death. And then the number of prevalent cases was 32,548. These are the number of people suffering from cancer in the year 2020. And so the burden is not small. And I think the next slide, I am trying to apportion this burden. I want you to note that cancer of the cervix accounts for 20.5% of all cancers. 20.5% of all cancers in Uganda are cancer of the cervix. That's how big it is. Now remember, this is a cancer you can prevent by vaccination. You can also prevent cancer of the cervix by screening. Because when we screen for cancer of the cervix, we are looking for pre-cancer phase, which we treat and cure. Yeah? But it still accounts for 20.5% of all cancers. This is huge. This is one cancer accounting for a fifth of all the cancers that we are seeing. And then Kaposi sarcoma 11.3, breast cancer 7.8, prostate cancer 7%. I think I want to just again say a little about the risk factors, because we shouldn't forget them. You're here for the people we serve, but you're also here for yourselves. You understand? I usually tell people that when we talk about health, this business we do also concerns us. Because today you're the doctor, tomorrow you're the patient. Today you're caretaker, tomorrow you're the one being taken care of. So this is, I try to paint the risk factor burden. So there is a high prevalence of oncogenic infections. You know that about 30% of all women in reproductive age have HPV infection. That's how common that risk factor is. But you also know that about 7% of Ugandans have HIV. That's how common that risk factor is. majority of Ugandans also have hepatitis B. Those are oncogenic infections. The good thing is, many of these now, we have interventions that target them. For HPV, we can vaccinate. For hepatitis B, we have a vaccine. For HIV, we have ARVs, and we are doing a good job. So we need to keep them at the top of our minds that they are common as we think about controlling cancer. But we also have rapid urbanization. There is an increase in towns, especially in small towns with slums. And we have industries that are growing, and really the pollution is not well managed. So we have to keep this at the back of our minds. If you go to any downtown part in this country, you get shocked of how contaminated the environment is. But also, our lifestyles are changing. People are eating high-calorie diets, eating less fruits, exercising less. If I ask people who have exercised this week to put up their hands, people would be embarrassed to participate. You understand what I mean? But these things we have to keep at the back of our minds. Now, I want to quickly show this table. This again shows the risk factor burden, but it really adds figures to what I've just said. Just to keep it at the back of your minds. Now, to talk about the plan itself. So this plan is organized in what we call chapters. Chapter 1 is basically the background. Chapter 2 has the vision, mission, and goals. Chapter 3 has the pillars. The pillars are like the sections of the plan. What somebody would come looking for in the cancer control plan. But that has to be supported by the background, and the vision and mission and objectives. Now, under the pillars, we have a pillar on health promotion and cancer prevention, early detection, diagnosis, palliative care, cancer survivorship, cancer surveillance and research, policy and advocacy, cancer control in children. Then the chapter 5 is cancer control in special interest groups, which I mentioned. And then we also have a chapter on governance and management, and then so we have a chapter on implementation of the plan. Now this is the detail of the plan, and I chose to flash the table of contents so that in case we don't go through the entire detail, at least you have an idea of what is contained in the plan. And this is what I have been doing every time I've been talking to people, is that when you show this, then you identify where your interest is. You understand? If you're a health educator, health promoter, you know where your interest is. If you're a palliative care, mutant, you know where your interest is. And this is really the core of our strategy. We want this plan to be for everybody. We don't want anyone to feel like that plan belongs to Dr. Magician. No. Because if you're a palliative care expert, there is a pillar on palliative care. If there are any strategies that you feel are lacking, it's your own. Propose an improvement. And so we hope that in the first year of implementing this plan, we'll gather enough information to update the next edition, and down the road that the country, the society can really own the plan. Now the overarching objectives, sort of the bigger objectives. Objective number 1 is strengthen the capacity in cancer prevention, early detection, curative, palliative care, and survivorship interventions in national health and development agenda. Now I want to remind you that a cancer control plan is not a health sector plan only, because health is fixed in the healthcare sector, but health is made in other sectors as well. In agriculture, in transport, that is where health is made. So this plan has got to be for every sector, for the entire society. And so we want this capacity to be enhanced in the development agenda, not just in the health sector. And then to promote partnership and collaboration in cancer control. And thank God you're all here. Want to make sure that we are promoting partnership and collaboration. but also to build cancer surveillance systems and research to support national planning and implementation of interventions. We want to make sure that we have built systems for surveillance, cancer surveillance, and what we mean here is where has the cancer occurred, what has caused it to occur, where are these patients, where are they receiving care from. And then also to be able to do research. We want locally generated research evidence. Every time I talk about cancer and there are people, they ask, but is there a place for herbs in treating cancer? And unfortunately the answer I usually have is like, I think there is a place, but we don't know enough. You understand? And these things we need to make sure we build the capacity to do research in them. Because even if we pretend, Ugandans are using herbs. Whether they are doctors on cancer treatment, whether they are lawyers, whether they are ministers, they are using herbs. And the only good thing we can do for them and for ourselves is to have information to be able to guide us and them. But also to set standards and coordinate interventions across implementing stakeholders. We don't want to waste resources. We want to make sure that as we implement, we are dancing the same tune, that no one is duplicating what the other person has done and not adding value. Now I want, again, I am trying to make sure, I wish somebody, when I have 5 minutes, just let me know. Yes. I want to just dive into the pillars. Now I am not going to show you the details of the pillars again because it will take us the whole day. But pillar number 1 is health promotion and cancer prevention. And listen to why we called it health promotion. Is because some of the cancer prevention interventions address other diseases as well. One example of a health intervention for cancer prevention is physical activity. That is a good intervention for hypertension, for diabetes, for many other and healthy conditions. And so we didn't want to say cancer prevention alone. We decided to have an embracing pillar and say health promotion and cancer prevention. And then each of the pillars, now this is important for you to know, especially when you later get the booklet, that under each of the pillars we have strategic objectives, which is in the first column. This is sort of a broader objective. For instance, to reduce modifiable cancer risk factors. This is at a higher level. But then there are specific objectives. Under the modifiable cancer risk factors, reducing them, we want to increase coverage of vaccination against vaccine-preventable cancer-causing viruses. And here we highlighted hepatitis B, hepatitis viruses, and HPV. Those are the specific objectives. I hope that makes sense. Because I want you to be part of, to believe in this plan and really feel you own it. Are we together? So we have a strategic objective and a specific objective. And then under each of the specific objectives, we have what we have called key interventions. And our aim here was this, that when we have a strategic objective, we have a specific objective that shows you what you're going to do. You're going to increase coverage of vaccination against HPV. Now, if you deal with vaccines, you now have what to do. Make sure the vaccine supplies are enough. If you're managing a health center, make sure you can vaccinate against HPV. But we also want to highlight the key interventions that we sat down and thought of as key interventions. Educate the public on the need for universal immunization. And when we were writing this, we were hit hard that nowadays there are some districts where immunization coverage is actually below 50%. And for us, that is a time bomb. If immunization against polio falls to 20%, we will have polio again here. Things that we had forgotten about. I didn't want to highlight some of those districts, but they are there. The ones you can't even believe, whether including Wakiso, probably where we are. You understand what I mean? So these are the key interventions. Conduct community dialogue at the district level. Now what goes into the details comes now to the implementers. You know, how do you conduct the dialogue? Then maybe PCAU will see what to do. Maybe when we come to the palliative care pillar, then we will see what is really relevant to many of us here. But I want to invite us to be interested in the rest. But you can see interventions develop IEC materials, print and audio visuals. These are key interventions really specific to what is practically done. Now I think let me go to the next slide, to the next pillar, early detection. Now I want to remind us that when we talk about early detection, we are actually talking about screening and early diagnosis. Now we went actually through the definition of these terms. So when we talk about early detection, we are referring to screening and early diagnosis. And strategic objective here is to reduce the proportion of patients presenting with advanced cancer. That's the aim. If advanced cancer percentage is 80%, we want to reduce that to 60%. And then what are the specific objectives? To increase coverage of cervical, breast, and prostate cancer screening services. Now, in this first edition, we chose to focus on those three because we feel for these, we actually have what it takes to actually screen for them. You know? For other cancers like esophageal, colorectal, we don't have what it takes yet, but we believe we can build the capacity. And then when you look at the key intervention, we have developed a national cervical cancer elimination plan. Now this is already developed, and because we began writing this plan earlier, you know, when the ministry top management reviews it, we will have to update it before we produce it. Yeah? And then establish a childhood. Now I'm just in key intervention 2.2.1. Establish a childhood early diagnosis program for cancer. Now we just discovered that for children you can't screen for cancer because cancer in children is not a lifestyle disease. And so you can't identify children to screen, but you can diagnose cancers in children earlier. And so we want to establish an early diagnosis program for cancer in Uganda for children. And there are ways we can do that. So let's go to pillar number 3, which is diagnosis and treatment. Again, remember, I'm just giving us a snapshot. So for diagnosis and treatment, strategic objective number 1 is to improve access to accurate cancer diagnosis and effective treatment. Now when we were writing this, somebody says, but when you talk about diagnosis and you referring to accurate, and the constituency then said, no, include that. So that everyone who is implementing the plan remembers we want accurate. Not this is cancer and you have no evidence, you haven't done a histology to prove it is cancer. And we are saying this because we are in a time where breast cancer, just saying this is breast cancer is not enough. We want to know, what about the hormone receptors? Are they positive, are they negative? You know, because there are tumor markers we can look for in many cancers. We want to make sure that we have improved this capacity as well. And then you can look through the key intervention with specific objectives. And I want to beg that we move on because there's something important that I want to show us. Palliative care. I want us to go through this a bit slowly. So strategic objective for the palliative care pillar to improve the quality of life of cancer patients and their families by increasing access to palliative care services to all in need. Now this statement looks, loaded, but we discussed it a lot. I remember Dr. Manda was in this meeting when we wrote it. Specific objective number 1 is to integrate palliative care services in cancer care and treatment. Now we just acknowledge at this point that, for instance, at Uganda Cancer Institute, we don't have a palliative care department. We have a team, but not a department. Now, when you don't have a department, you can't develop the service much. Having a few nurses, really, you can't make a lot of progress. So I think one of the things we have here is establish palliative care departments at UCI and regional cancer centers, and establish palliative care units at regional referral hospitals. We didn't want to claim these should be departments because regional referral hospitals are going to be militaristic, that we don't have resources for departments. But for Cancer Institute, regional cancer centers, we think we can have departments there as part of this plan. And then develop human resource capacity for palliative care provision to cancer patients. Now, we acknowledged here that we do not have the human resource capacity to provide palliative care services to cancer patients. Because if you came at Uganda Cancer Institute, you actually find that the institute is wanting in terms of being able to deliver the appropriate palliative care services. And then you can see the key intervention for adoption of the palliative care policy. And then we have established home-based palliative care programs at each district, train health workers pre and in service in palliative care, and then advocate for the establishment of palliative care service providers and specialists in the formal public service structure. I think that time is Dr. Emmanuel Ruyirika, who was emphatic and saying people are trained but they are not being given positions. And that demoralizes and discourages people who have been trained and denies people, you know, benefiting from the expertise that has been built in these individuals. Now, you will allow me scroll through the survivorship, not really emphatically, but for the survivorship pillar, we acknowledge that we don't have any cancer survivorship program. People survive cancer and live on their own. Now, there are many groups that are supporting them, but we need a program at the national level that provides opportunity for cancer survivors to be able to live positively and economically productive. So the strategic objective here is to improve the quality of life of cancer survivors and their families by creating a supportive environment. So we want to increase access to rehabilitative services. I think we talked about establishing, you know, factories for prosthesis. You know, people get amputated, have their breasts removed. We make sure we have, you know, some factories that can make these devices for them. Now, we have a pillar on surveillance and research. Now, this, we believe, is going to be very, very fundamental in supporting the National Cancer Control Plan implementation and monitoring. Now, I want to go through this detail in the interest of time, but I want to take us to cancer control in children. Now, for the cancer control in children, what we did for this, we designed this according to the World Health Organization. There's a global initiative for cancer control in children, and we designed the cancer control, the chapter on cancer control in children in our plan according to the global initiative for cancer control in children, which is the World Health Organization initiative. And for this, we are working with World Health Organization and St. Jude Children's Research Hospital to develop a separate booklet for cancer control in children. The aim for this is to make sure that we do not leave children alone. If anything, yesterday evening we had a meeting to discuss this in detail. We want to have the National Cancer Control Plan approved and being implemented, but we make sure that the one for children is also coming in line. And we want this to be the same for other stakeholders that have special interests. You know, you can have a cancer control, you know, a pull-out for palliative care. We have a pull-out for a certain group. We want these things to come because we believe these will be opportunities to mobilize resources and align players to achieve the objectives that we have. And then the chapter on cancer control in special interest groups, we didn't put too much detail because we would want, when we are implementing this plan, to go and develop it further. We found that, for instance, people living with albinism, there's a lot of information we don't have to be able to have specific interventions for them. But we've created a platform to be able to have stakeholders be able to develop these chapters into separate booklets, so that, you know, it's small, maybe 20 pages, but it focuses on that specific group. Because some of them have resources that are meant to support cancer control, be aligned to achieve those objectives. Now, we also have a section that details the expected minimum cancer control services by level of health facility. I want you to listen carefully, that we decided that we are going to write out the minimum cancer control services at the national level, national referral level, district hospital, health center 4, health center 3. Because we wanted that when we have this plan approved, then it's not very, very difficult for the implementer to be able to do something right away. Yeah? And for us, we think this is an example, even for other sectors. If it's in agriculture, what can be done at the district level? Is it supporting farmers to use herbicides properly? You know? Not implementing the plan and let alone monitoring it. I don't know whether that makes sense. Now, we also have a section on cervical cancer control. The reason is, cervical cancer accounts for 20.5%. And it's actually a target cancer at the global level to eliminate. So we thought we would be shooting ourselves in the foot if we do not have, you know, a small section for it. It's not big, but we want to make sure that we are capturing it. This is now implementing the plan. I hope I still have time. Now, this is the cost of implementing the plan. I am pausing because it has raised a lot of red flags. Yeah? When you look at this cost, initially we had put actually years, in terms of 2024, but we later dropped and said year 1, year 2, year 3, year 4, because we realized we are not keeping in pace with the time in terms of the years, but the moment it's endorsed and approved, then we will put the dates in terms of 2024, 2025. So I want to invite you to see that the biggest proportion of expenditure on implementing this plan is actually on diagnosis and treatment. And why I want to discuss this with this small group is to be able to make sure you appreciate why we are portioned this expenditure this way. When you're starting to implement a plan like a national cancer control plan, you're starting with, you remember the burden of patients we had? 34,000 diagnosed in 1 year. So cognizant of that fact that we have a lot of patients who need care and are sleeping on the verandas in Cancer Institute, which is just 10% of the patients in the country, we are cognizant of the fact that even if we begin prevention drives, there is a lot of suffering. People are already sick. Yeah? And so, in the first term of this plan, we are asking for more investment in treatment capacity. So that we have now a linear accelerator at Uganda Cancer Institute, but we want to have a second linear accelerator in the term of this plan. Yeah? We are building 6 bunkers at the Uganda Cancer Institute, and 2 of them are equipped. We want to equip the other 4. So that as we implement the plan, also the patients who are being diagnosed are receiving care. Because when we do not give care to patients, then we demoralize even the other people in the community. You know, when you're burying people, then you cannot begin singing a song about cancer. I hope that makes sense. Now, some people have said, no, there should be more money in prevention. But we are saying, no, it's too early to invest too much in prevention when we are not treating the people we have in our houses. Yeah? I hope that makes sense to us. And so there is a lot of investment in high-tech cancer treatment equipment. Now we also want to invest in establishing regional cancer centers. I have met people at the international level who do not agree with decentralizing cancer care. And the reasons they give is like, even when you go to the US, you find like 5 states have only one public cancer care hospital. But you see, the setting there is different from here. Our challenges are much bigger. That to have a patient come from Kisoro and get care at Cancer Institute, even if the care is for free, they will not come. You know? And so we want to make sure there is a care center closer to them, where somebody can visit from home and go back. Because, you know, we have to visit and bring food from home to hospital. You understand? We don't bring money for them to buy food, because we have food at home. We just harvested millet, so we have to make porridge and bring in a jerrycan. So we want to make sure that we have regional cancer centers where our families can support our patients. We just learned that to ask patients cross from Jinja to come to Kampala, you lose many. People from the east want to get care from Jinja Hospital because they don't cross the Nile. When you cross the Nile, the social dynamics change. You understand what I mean? The same applies to crossing Karuma. If you want people from Arua to come to Kampala, if you put a center in Arua, you'll have more people treated. Otherwise, you say cross Karuma and go to the center. It becomes problematic. So, and as I speak now, the Guru Regional Cancer Center is equipped. We have advertised to recruit people to deploy there. You know? Meaning that this calendar year, the Guru Regional Cancer Center is going to be fully functional. It won't have all the services, radiotherapy and all, you know, but it will be able to take care of probably over 50% of patients that come from there. The Mbarara Regional Cancer Center is fully functional. The university has given us land 4 acres to build a regional cancer center. So this is where now the investment is going. So we suspect that even the second term of the plan, we'll have to still invest in care. Because without investing in care, we will not be doing ourselves a good service. And of course, the next proportion, the highest proportion goes to health promotion and cancer diagnosis, where we would want to gravitate most of the resources, but not at this point. All right, now you can see that the total cost of implementing this plan is going to be $170 million US. That's not a lot of money. I wanted to just mention this, that the governance and management of implementing this plan is based on the Uganda national. The governance and management implementing this plan is going to be coordinated. Listen carefully, this raises a lot of eyebrows. It's going to be coordinated by the Prime Minister's office. And the reason is this is a multi-sector plan. It cannot be coordinated by the Ministry of Health, because the Ministry of Health cannot summon the Ministry of Agriculture to weigh heavily on the use of herbicides and the storage of produce and things like that. Yeah? So there's going to be a steering committee at the Prime Minister's office to coordinate this. And when we present to top management, which we will do soon, because we've asked to be given an agenda item on the next meeting of top management and the Ministry of Health, we don't have control over that, but we've put in a formal request. We presented to senior management committee, you know, until top management. When we present to top management, then the minister will take it to cabinet. There we will not go. We will go there to support. If she asks us to talk, we will talk. But she's the one to. And so the next phase is where we present to top management, and then, they will tear it apart for the minister to understand what it means, and then present it to the next level. But what we are proposing to them is that we are proposing the Prime Minister's office coordinates, but the top management rests with the authority to decide how the implementation is done. But we have no doubt that they will accept that the Prime Minister's office sort of oversees the implementation. The Ministry of Health is going to be the technical arm that guides. Yeah, but the Prime Minister's office will take the oversight, the oversight role. Thank you. And I wanted those 5 minutes for questions. So let me see whether I have anything to emphasize. No, I think allow me stop here, and then those 5 minutes we can ask questions, because I want to hear from you. The presenter is coming. Any questions? I don't think I can. Now, I've been told there's going to be a question and answer at the end, and I think that is the strategy of the organizers so that we save time. So you can, if you have a burning question, ask. This is still within my time. Yeah? If you have a burning question, you can ask. But still, you can write it down, then we answer it later. But I want to remind you that at exactly 11, I want to leave. Because I already told you. Yes. Thank you very much. I think I will stop there and hand over to the chair.
Thank you so much, Dr. Mugisha. I think we have all had a very exhaustive presentation from him. Thank you so much, Dr. Mugisha. Without wasting time, no, we had requested that let them type in the chat, then Dr. Mugisha will ask us and when we finish the second presentation, in order for us to save time. So I'm going to call upon Mr. Dennis Olodi, who is online. He's the Executive Director of the Uganda Cancer Society. Dennis, before joining UCS, Dennis worked with Gulu University as a lecturer in the Department of Public Administration and Management. He has extensive experience in civil society space, specifically in areas of health, education, livelihood, governance, and human rights. He worked with Global Forum for Development, National NGO Forum, Northern Uganda Social Action Fund Program, as well as International Republic Institute. Olodi has also served on many boards, Uganda Rotary Cancer Program, Dilaru, and Platform for Community Empowerment, among others. He has a training background in management, policy development and analysis, as well as political science. So Dennis is going to talk about the findings of a study on patients' involvement in service delivery. He's joining us online, and I'm going to welcome Dennis to make his presentation. Thereafter, we'll have a Q&A session. Okay, I think as Dennis sorts himself out, I'm requesting for us to ask questions to Dr. Mugisha so that we can save time. Do you have any questions online? And people here, do you have any questions that you want to share with, to ask Dr. Mugisha as we wait for Dennis to join? Dr. Eki. Yes, Dr. Eki.
When you are talking about implementation, that's why I'm asking, is the human resource embedded there in these pillars? Thank you very much.
Thank you, Dr. Eki. Any other questions so that you can take at least 3?
Yes, good morning. Good morning, members. I'm called Joanita Babas. I work with Rays of Hope Hospice, Ginger. Thank you, Dr. Mugisha, for the presentation. Mine is a concern that I would like to speak on behalf of the patients. We happen to care for cancer patients who receive care from Cancer Institute. Previously, those who have been receiving radiotherapy, the cost was a little bit manageable. We happen to support some of them. But since this year started, the cost has risen. I think I understand that a new machine has come in place, just as you have mentioned that we want to, you as the cancer management control plan, we want to make sure that you're investing a lot in diagnosis and treatment. We are so happy for that. But the cost is too high. And most of these patients cannot afford. Actually, what we have been doing is that we say, let's cost share. We give you half, and then you bring half. But the reality is that most patients cannot afford. So I am asking, is there any plan to either reduce the cost or you to cost share with the patients? Thank you.
Thank you for that question. Any other questions?
A student of Bachelor's Palliative Care at Institute of Hospice and Palliative Care in Africa. When you are presenting about cancer control in special interest groups, you listed only 3, the albinos, refugees, and people living with HIV/AIDS. But I think this is a wider group. How about the prisoners, people in armed forces, the elderly, the sex workers, the destitutes? I don't know what you have, or what plan you have for such groups. Thank you.
Thank you so much.
Since most of the questions are for people who are not here. Yeah, thank you very much for the questions. One, on the question on training of human resource to implement the National Cancer Control Plan is actually embedded in each of the pillars. If you remember when I was highlighting the interventions, the key interventions for palliative care pillar, we talked about PURI and in-service training. So in each of the pillars, training of the human resource is integrated in the pillar. And why we did it that way is that the need cuts across. So there's no way we could have a standalone pillar. And we cannot have resources. I'm getting echoes, I think. Do I need to stand somewhere? Can you hear me, all of you? Maybe mute the speaker here. So I hope that one I have addressed it. We would wish that for each pillar, the stakeholders will be able to identify the resources, the human resource capacity that is needed, and then they'll be able to find the interventions, key interventions in there that address that need. Otherwise, at some point, we thought we'd have a pillar on human resource, but realized it's going to be very difficult to get one pillar and be able to cater for each of the pillars. Then number two, the cost of radiotherapy increasing. This is true. 2 days ago, a colleague was calling me about the cost of radiotherapy for a patient, and I want to commit that I'm going to give this feedback to the top management of Uganda Cancer Institute so that they know. But for you to know why the cost was put is because the reason is that we do not want the machine to have a problem and then we suspend service because we cannot fix it. That's really the reason behind the costs, that the maintenance of this machine needs to be continuous, and when we budget for them, usually that's the budget that is slashed. So the reason for introducing the cost, that was the reason. Now, the cost being high is a different subject that actually is subject for discussion with the management and the board of the UCI. And I hope that if you could send like an email or a message so I can forward it, it becomes more appealing when a message comes from you and I just forward it, rather than me going and reporting it. I hope that makes sense. But to say this message has come from Mark from PCAU, and here it is, and it's an email, you know, it's received as if... I hope that makes sense. Yes. And you can even forward it to, you know, I think I'll ask the secretary to share my email address, and then you can, because when you share it to my email address, then I take responsibility of making sure it has gone to the right person. The plans to reduce the cost, I don't want to say yes, I don't want to say no, but it's something that definitely will be discussed, because Uganda Cancer Institute is a government institution, the investment is by the government, and so it's definitely something that will be discussed. Now, special interest groups, this has always raised interest. Now, why we chose those three? Now, I want you to know that the choice is not real very scientific, that we went through a scientific process. But one, like people with albinism, in the process as we developed the plan, they came to us and they said, we are unique. The things we need to prevent cancer in us, like sunscreen creams, are considered as cosmetics. But for us, they are medicine. They are like food for us. And they actually had their own resources, you know, to address some of these things. And so we thought that it wouldn't be fair for us to simply keep mentioning them in some of the interventions. We would rather have them as pointed out so that they are able to get the plan and say, here we are. Speaker of Parliament, here we are in this plan. And then for the refugees, Uganda hosts one of the largest populations of refugees in the world, actually. There's actually a district that is called the United Nations, Chiriandongo, because, probably half the population are not Ugandans. And so, and again, refugees, even though we claim to offer free health care to them, the process of accessing this health care is not straightforward. If you've tried to support a refugee, you know how difficult it is. They are supported by UNHCR through the Prime Minister's office, yet they are supposed to receive health services from a certain hospital. So when drugs are not there, they need to go to UNHCR to get money to buy the drugs. So we want to be able to develop interventions that will streamline their care, at least as far as cancer is concerned. Now, the special interest groups number can increase as much as we want, as long as we have strategies to address certain challenges for them. Remember, this plan is a resource mobilization tool as well. Yeah, I know we have now, the government has a plan for the elderly. They receive a certain amount of money. I don't know whether every year or but that could be a special interest group as well. But for the first edition of the plan, and then for the people living with HIV, these people are at high risk of developing cancer. Majority of them are enrolled in HIV care services. So we feel they are a very easy population to target. They attend certain clinics, they are registered somewhere, and yet they are the majority with cancer of the cervix, presenting late, yet receiving care every 6 months. So those were some of the reasons of choosing these groups. But I want you to know that if there is a group you feel we should include, it can come in the next edition. There is completely no reason not to include a group at this point. I hope that makes sense. And we call them we never called them special groups. We call them special interest groups. Because we thought if we say special groups, then everyone is special. Now we said interest groups because we had reasons for saying we are interested in them. Now those other groups that you have reason to be interested in them, please forward them, because then we'll also have reasons for being interested in them. I hope that makes sense. Otherwise, women should be a special interest group. They are shouldering 20% of the cancers in the country. That's why we have a special book for cancer control, for cervical cancer control. I hope that makes sense. And I gave you reasons why we have a special pull-out for cancer control in children. Thank you.
Thank you, Dr. Mugisha. Is Dennis online? Yes, there's a question. I just wanted to find out if Dennis was online so that we can, he's not, eh? Okay, so there's another question from Diana. Dr. Mugisha, what are the reasons for choosing the 3 groups? I think you've mentioned it. That's the first question. The second one is, I wonder if the statistics of diagnosis are based on those reporting to UCI. How do you intend to reach those in the community? And how do you intend to reach those in the community and are not able to access a hospital? I'm sure there are cases that remain undiagnosed.
One is that the statistics here are not based on those reporting at Uganda Cancer Institute, because now we actually know that at Uganda Cancer Institute we take care of between 10 and 20% of cancer patients in Uganda. Meaning that there is another 80% that is not receiving appropriate care. But the statistics are based on the Kampala Cancer Registry, which is the most comprehensive population cancer registry that we have in Uganda. It's on that data that we based the 34,008 people diagnosed with cancer in 2020. And then how are we intending to reach those in the community? I think in the plan, we actually have strategies to use village health team members to increase cancer awareness. Now, when we increase cancer awareness, then we trust that people who develop cancer will know this is cancer because they are aware of the symptoms and signs. Then they will be able to report to health facilities. Whether we are able to encourage 10% of those who are there, 5%, 80, 90 is a different question. But at least the starting point is to use the already established structure to reach them with information and encourage them to come. And we hope that even in the first term of the plan, we'll be able to have at least cancer awareness services even at a health center 3. So that when they are giving health education and nutrition and immunization, that information also has cancer messages in it. Because this is already happening during the immunization days. Thank you.
Thank you, Dr. Mugisha. I'm told that Dennis is now online. Thank you. Is he on and ready? Okay, before Dennis makes his presentation, I just want to recognize the organizations that have come here physically. I'd like to recognize National Medical Stores. Thank you for coming. American Cancer Society, Uganda Cancer Society, Uganda Cancer Institute, Hospice Africa Uganda, Lira Regional Referral Hospital, Mama Maria HC, Kamuli Mission Hospital, Rays of Hope Hospice Ginger, UNAD, Nsambia Training School, Bombo General Military Hospital, and all the PCAU branches online, which include Budu branch, Kasese branch, Elgon Mbale branch, Hoima branch, Busoga branch, Mitiana branch, Arua / West Nile branch, and all other organizations that are online that have managed to join us today. Thank you so much for making the time to join us. I'd like now to welcome Dennis to make his presentation. So let's go with the online questions now. this one is from German. Okay, thank you, Dr. Mugisha, for a wonderful presentation. I would like to know as to whether the Uganda National Cancer Control Plan has taken into consideration other factors that have been that have significant bearing on cancer care, e.g., traditional and contemporary medicine.
Thank you very much for that question. I was waiting for others so that I can respond at once. But yes, how we've taken care of that is in the aspect of research. Because even though we have a lot of, let me call them traditional medicines, herbs, and all these other things, we do not have like empirical evidence of how they work. And if we were to formalize them, then we need to do some basic research on them. And there are many Ugandans who are involved in actually herbal research. You remember Covidex? You know, that's a herb. So we've taken care of that. And we think anyone that thinks they have something traditionally that they have been using that contributes to cancer care, then that's the avenue we would want to exploit that opportunity and benefit from it. Then somebody talked about Bunyoro region, Changwali, hosting many refugees. I need to decentralize cancer services to there. Maybe I should just say it this way, that cancer care is not like treating malaria, which is a short-term care, where you go, they test for malaria, they give you tablets, you go home. Cancer care is a bit complex. So you cannot have very many cancer care centers, because to build that capacity takes time. First of all, the doctors have to have additional training. The nurses have to. The equipment we are talking about is not that you can easily have that equipment in a place. The only thing we would need to have for such a region is to have a mechanism of supporting patients there to access services. Just remembering that refugees come with a lot of other needs that are just beyond cancer care. So just providing cancer services alone, they may not even access, even when the services are there. So I think that is something that can be discussed again, but in this particular edition of the plan, it had a provision for decentralizing cancer services for that region. But I can tell you, if the services are in Mbarara, they are in Gulu, they are in Arua, these people can access those services as long as there is a clear mechanism of them accessing services. I don't know whether that makes sense. Yes, thank you.
Okay, thank you, Dr. Mugisha. Do you have any other questions online? And it seems Dennis has still failed to join us. Okay. Christine?
issues that we picked in the focus group discussions we had with patients. And after picking these issues, we categorized the responses into what you can see. Column 1 is for patient engagement. Patient engagement really came out strongly. And if you look at the patient engagement, which they said wasn't sufficient, there are key themes, key issues they raised there. The first issue there is that they need patient engagement forums. One of the participants indicated that as patients, they're always left behind many times, and yet sometimes they have challenges and have no opportunity or avenue to express their challenges. So they expressed that there is need for patient engagement forums to be created at facility level, whereby health workers get to pick views of cancer patients around how they feel they should be served. If you look at the second theme there again, I think the presentation has dropped, but I think I can. Another issue there was on patient involvement. I do not know if you can project it, but on patient involvement, they said that they feel they should be involved and their input should be considered over and beyond the opinions of doctors around the treatment they are supposed to go to take, the length of treatment and things like that. But considering their opinion is on a low note, it is not at the center stage. Then another issue, I do not know if you're projecting on the other end because I can't see your screen.
We have a projection here. And we are talking, the slide okay. That we are seeing is key issues raised by patients.
Yes. Another issue was communication in research, where patients indicated that many times researchers come and take information, including their samples, but they never come back to share results or information about the studies. So they are forced to think people are making money off them. So part of what they said is that whenever we do studies, effort should be made to communicate findings of such studies, because most times they are forced to think researchers come and make money off them. They use them to make money. Then another issue which they raised is that on decision-making forums, there should be patient representation, not only at the board level and management and things like that. They should say even at operational levels or even at tactical levels, there should be patient representatives to provide or to offer the patient's voice and many other things. Then another thing was on patient protections, where somebody said some patients feel used during studies. I think that also alludes to what I said earlier. I would like to usher us straight to the next slide. I've been told I have 20 minutes, so I'll have to work within that time. You can take us to the next slide. Yes. Again, there was another prominent issue which came up with patient support. And under patient support, we had about 4 themes. The first theme or issue which we captured there was that counseling still remains a very big gap, especially peer-to-peer counseling. That there is professional counseling which is provided at facility level. But as patients, they would also want to have peer-to-peer counseling. They would want to be talked to by cancer survivors who have walked similar journeys, and such counseling helps to inspire them on their treatment journey. So they said that is a gap, and you can see the attendant quotes there. Also, another issue was accommodation. They said they had accommodation issues where they had to migrate from one veranda to another, and when we presented findings together with APCA to UCI management, they said that an effort would be in place to establish a care home And I think from the time when we presented this study finding, UCI decided to establish a care home, which is currently accommodating cancer patients and working. Of course, the linkage between the care home and the hostels still need to be further strengthened because UCI remains the only national treatment center. Then there was also an issue of patient support and touching on transport. Why they said they need support as many lose their source of livelihood. That by the time they travel to the Cancer Institute or to the National Cancer Treatment Center, it means they have exhausted all the lower health facilities. And reaching here means you have exhausted your resources. So cost of transport is also another very, very big problem. Then they also indicated that there was an issue of patient abandonment. Caregivers coming to the facility because of trauma and things like that, they decide to abandon patients. So actually, some of them indicated, like you will see in the women's group quoted there, that families and friends ignore or do not engage them anymore. So this has been a very, very, very strong case here, and we have witnessed on many occasions. I would like to usher us straight to the next slide. The next slide was wider issues on health concerns. The first issue there was treatment side effects. So they, like the first person there from the men's group indicated that sometimes side effects of the medication made them stay away from treatment for a while. Then another group also indicated that cost of treatment is usually high. Most times those drugs which are cheap are at the pharmacy, then let the expensive drugs or medicines be at facility level, then the cheap ones can be bought from pharmacy or stores. So this was a very important thing here. Then somebody said there are things to do with psychological changes, physiological changes, that they have capacity. Some of these cancer patients are professionals, but because of the job, because of the disease, they have to change their type of job. So because your body has been weakened, say you used to doing hard work. So they said occupational therapy is very much needed. And this one came from the men's group, that they need occupational therapy because you are admitted for treatment and the treatment has taken 3 years, your body has been worn off. So they said this becomes challenging, especially those who were doing hard work before they fell sick. Then somebody said there was an issue of contingency medication where somebody is quoted here to have said, sometimes I buy normal painkillers, but the ordinary ones do not ease the pain. So when it's extreme, I come to the hospital to get better medicines. So this one came from the women's group, and this specific one was in reference to the time of COVID, where somebody indicated that they ran out of medicine, but because there was a ban on movement or public transportation, so even accessing medicine, yes, back in the community they have painkillers, but those ordinary ones do not ease pain. So sometimes they were forced to move to facility nearby, but even after some time, the such facilities ran out of painkillers. Then somebody said there was an issue of victimization, where a man is quoted here saying, we are being chased and considered as though we are not patients and get stressed because we are chased from the verandas, but this is not our choice. It's not our choice to fall sick. So we need our voice to raise our concerns. And this also speaks on to patients' representation, whereby they said at every level of service delivery, there should be patient representative to voice concerns of candidates. I do not know if my speed is okay. If my speed is not okay, please advise me to lower it a bit. I'm very fast. Rosie, is it okay?
Yes, it is.
Okay, let's go to the next slide. Pardon? I beg your pardon?
We are not seeing the slides.
Oh, it's being projected from the secretariat. I hope they can see it, but kindly project the slide because I'm just following from
The
mine
slides
here.
are already projected. Is everybody online not seeing the slides?
Oh. Yeah, we can now see.
Okay.
I can now see. Okay, then another category of response was in regard to patient navigation. That is on the first column. And then under patient coordination navigation, 3 key issues emerged. One is communication channel. The next is cancer information needs. The third is language barrier. Regarding communication channel, they say there is need for reception point to be well marked, and any changes put if it is shift. No, in February like now, then you come back in April. If reception center used to be in a tent opposite, maybe say Fred Hatch or any other building at PCI, you will find the reception point has been shifted to another location. But there is no signage indicating that we have shifted from point A to point B, and it usually affects those patients coming from upcountry, rural communities. Then another person said, oh, we need to have toll-free lines. Toll-free lines would really help because sometimes it's hard to get help. This was from a patient in Bundibuju. She said she had run out of medicine and she couldn't travel back, but she needed somebody to put medicine on the bus. And this also brought conversations around things of telecounseling or telemedicine, which is a big problem in the country. That if we have emergency situation like COVID-19 leading to lockdown, and you have patients in Bundibujo, say in Karamoja or in Dororo, and they have run out of medicine, what infrastructure do we have in place to support delivery of such medicines? So this also brought such conversation in place. Then another thematic area was on cancer information needs. This patient is quoted here saying that sometimes they are not properly explained to the different benefits or disadvantages. For example, changes in medication made. Sometimes you just wake up to find you're vomiting, your hair is falling off and things like that. So it's important that at the navigation stage, they communicate to them the changes that they're going to be experiencing as they change their medication. Then things of information on risk factors, lifestyle, and even nutrition came in very strongly. And they said, a health worker A will come and say, don't eat meat. Then another health worker will say, you can eat, but eat in moderation. Then another will come and say, eat this, eat that. So as patients, they get confused. They don't know who has the right information. Because there's a woman who confessed that for her, from childhood up to the age of 52, she has lived taking or drinking milk. Then somebody said, you stop milk. And for her, she can't. The only thing she can do is now to choose to die because she can't stop on milk. She can't stop milk. So the cancer information needs still a very big problem, and specifically titled on the risk factors and even nutrition component, which is still not very strong. So they said that has to be addressed. Another issue, which is a final one under the patient navigation still, is the language barrier. They said there is a barrier in communication right from the gate, and limited effort is made to try and translate information to patients. A gateman will speak Luganda even when the patient comes from a diverse background. And this one came from patients who are from non-Luganda speaking communities, that you're from Karamoja or from Teso, you don't understand Luganda, but the askari at the gate is speaking to you in Luganda. Even when you go to the wards, they're speaking to you in Luganda. And that language barrier becomes a very big component. And I'm happy, I should express on this call, that our partner, Palliative Care Association of Uganda, has demonstrated greater readiness to embrace some of these communication channels. Right on this call, we have a sign language interpreter. And I think that is a very good move by PCAU. If at facility level we could think of even having sign language interpreters. Some can be supported with resources raised by civil society. If we can have sign language interpreters, we also have issues of refugees like Dr. Nole captured in the National Cancer Control Plan, where you have refugees coming from Congo, Sudan, and they're seeking services here. Some of them speak Sudanic languages. I don't think you have staff at the UCI or facilities here who have good command of Sudanic languages. So language barrier is still a challenge. Yes, so you can take me straight to the next slide. So that is basically what we were able to capture during the study. I summarized in the interest of time, but I have a full report on the study, and the study can inform a number of programmatic interventions for civil society and even for the mainstream government. But I should also say to you that in a bid to address some of these things, we have also conducted a number of initiatives to support the National Cancer Control Plan, some of which came from this study, some from other studies, like we are currently holding quarterly dialogues targeting cancer patients. And we want cancer patients to engage with stakeholders in the categories of policymakers, service providers, and non-stake actors. And the reason we are doing this is because, like I stated at the genesis of my presentation, patient involvement in the low and middle income countries is still low, and yet patient involvement from documented studies show that if there is meaningful involvement, we can realize greater outcomes. So as a society, we are focusing on holding these engagements, and the reason we are doing it is because even the law, the Constitution of Uganda, under the national objectives and directive principles of state policy supports that, but also even the Patients Charter supports that. And right now that we're developing the National Cancer Control Plan, the government of Uganda, through the Cabinet Secretariat in 2013, came up with a guide to policy making. And under the guide to policy making, there is an aspect of stakeholder participation. A constituent group which the policy is going to affect must be primary stakeholders in the development process. And we have conducted a number of initiatives together with the Uganda Cancer Institute to try to harness or collect views of cancer patients, because they are going to be central to making and execution of the plan once it has been adopted by the Ministry of Health. And also the Guide to Good Regulation and Guide to Regulatory Impact Assessment clearly speculates that the constituent group should be heavily involved as primary stakeholders. Whether it's a palliative care policy, it means palliative care patients should be heavily involved. If it is a national cancer control plan, then cancer patients should be heavily involved. Forgive me, my background is a bit noisy, but I hope that you can hear me. And at this stage, I would like to request the person projecting to lead us straight to the next slide, which is patients in policy.
Dennis,
also, the reason we... Yes.
Dennis, you should be winding up because you're past
yes,
the
I'm
20
just winding
minutes.
up.
Yes.
And also, the reason we're involving patients is because we want the National Cancer Control Plan to be coherent and also should be soundly based. And also the sector-wide approach, which is the approach to planning the country, recommends that we conduct that. Just as I head to the next slide, which is the last slide, is why are we doing this? Is because from the efforts that we have been having in place, and also the recommendation of the study which we did, that we saw the need to increase patients' involvement. And I call upon all of us stakeholders to increase patients' involvement in decision making, not only at management and board level, but even at operational level. We need to involve cancer patients. Then two is because patients provide lived experiences as frontline people. Then also it's because it's a good practice in developing policies and plans in the country. And also there is this saying that nothing for us without us. So for us, when we involve cancer patients, we do that to secure public confidence and also to build momentum for implementation of the National Cancer Control Plan. The last slide speaks onto references. We have a number of studies conducted to support patient involvement in decision making, in research studies, and in cancer service delivery. With that, I have to hand over back to you, but I would like to say to all participants, thank you for listening to me. I do not see any possibility of rewarding you for the patience you have had with me. I thank you.
Thank you so much, Dennis. Can we give him a very big round of applause? Thank you so much, Dennis, for that presentation. And it's good to know that some of the findings that you presented have started being implemented by the Uganda Cancer Society. So at this juncture, I'd like to welcome questions for Dennis. Right now, for those online, Dr. Mugisha has left because he has a prior engagement at midday, so he left. Joyce will be sharing with us Dr. Mugisha's email so that we can forward him some questions regarding the National Cancer Control Plan, but also regarding the issue of the radiotherapy cost being high. He told us that we can share with him emails so that he can share with his other team at the Institute. So Joyce will be sharing that with us. Now I'm requesting us with questions, comments, to please bring them up for Dennis. Do you have any? As we wait for the questions, I'm going to ask Joyce, because I want us to save time. We're supposed to end at 11, but it's now 10 past 11. So let me ask Joyce to come and also make a presentation and give us an update from PCAU.
Thank you so much. Good morning once again. It's going to be very brief, and we really appreciate your patience. From the Palliative Care Association of Uganda, my name is Joyce Zarango. I work as the Capacity Building Manager, and I want to thank you all for the great support to the Palliative Care Association and to the palliative care work development in this country. We have a few highlights to share as the Secretariat, and one I'll go through I'll follow our focus areas that we look at. From the capacity building area, we want to thank God that we have the intake for the advanced diploma in palliative care nursing already at Mulago taking place, and PCAU is giving close to 30 scholarships. We have been pursuing accreditation of the institution to offer CPD points with all the professional bodies, and we believe we are doing well with the Uganda Nurses and Midwifery Council. We'll be able to offer CPD points for every CME offered with us. And we are working towards that for all the other professional bodies, that is the Allied Professional Council, where we have our clinical officers, as well as the Medical Council, where we have our doctors. In the area of advocacy, we had Dr. Mugisha mentioning that we are still limited with palliative care human resource. And I want to thank all the institutions that are contributing to build the mass for palliative care human resource, and that leading, that is Hospice Africa Uganda, through the Institute of Hospice and Palliative Care in Africa. So we know that we will build this. We have Malme Uganda doing the pediatric palliative care, and we have Mulago School of Nursing with the advanced diploma in palliative care. So we continue to advocate to see that institutions, universities take on this to increase the mass. Coupled with advocacy, we have positions created, and we have 13 positions at the Uganda Cancer Institute, like Dr. Mugisha mentioned, and this will be for the Department of Palliative Care. We have the Uganda Heart Institute that has got 6 positions for palliative care officers. We have Mulago National Referral Hospital that has a whole department planned to have 13 officers in palliative care. And also at Health Center 4s and Health Center 3s, we will have Assistant Nursing Officer Palliative Care. That deserves a hand clap. So we appreciate the advocacy the Secretariat is doing together with the partners and the members to ensure that we walk that milestone. The other thing is the recognition of trained clinical officers and nurses in the Narcotic Drug and Psychotropic Substance Control Act 2023. We want to thank all the participants that led us in this. Let's clap for them. That recognizes the trained people to continue providing the service, especially ensuring there is pain control. We have our AGM that will be coming on the 31st of May. Please mark your calendars. But before the AGM, we will have a pre-AGM update meeting or webinar, and that will be held on the 24th of May. Please mark your calendars and join us in that. As the Palliative Care Association of Uganda, this year we'll be marking 25 years since establishment, and that's a silver jubilee to us. The birthday is on 22nd of July. So we need to give Baby Palliative Care Association of Uganda a cake on that day. We also have to commemorate the World Hospice and Palliative Care Day that we plan for. And since we are celebrating 25 years of existence of supporting advocacy, capacity building, research, it will be a series of events happening, and we'll be communicating to you on each and every point. And that will come last. We have a baby for this month. I think every update meeting we will be celebrating a birthday for a member who will be present and who has communicated. I know our membership and partnership officer, Fiona Sima, thank you so much.
Good afternoon. Please clap for our presenters. We are very grateful. I really struggled to keep Noreb here so that we can finish with him. I was at Makerere when Noreb was at Makerere, and we were in a very small fellowship, and we got married to the wives that we related with in the same group. And so I knew why he was leaving, but I wanted him to leave when we finished together. Now, Joyce has thanked you. I'm only adding my voice to thank you for coming. Please, thank you for coming. For those who have been online, I have seen we had over 90 people like logged in online, but I know that regional referral hospitals had boardrooms which are full. I saw one in Masaka. I think they are the fullest. I saw people in Arua. I saw people in Jinja. I saw people in Barara. I saw people in Busoga. The Budu branch of PCAU is very vibrant. I saw people. So we thank you so much for the commitment, for the passion. People from the Rays of Hope who traveled from Jinja to be here on time. People like Teopista who never miss. People from Bombo, I've seen the soldier here. And I've also seen someone from Kisoro who have come from all the way to come and attend from here. Thank you so much. Joyce has mentioned everything that we plan, but not exhaustively. I just want you to send her an email and follow up on the accreditation by the Nursing Council, which has allowed or approved our request that we can award CPD points for nurses who attend such sessions. You didn't clap for it, but they really had a lot of struggle to make sure they get the accreditation. reviewing our strategic plan, we will come to you. We can't be everywhere, so we will be asking some of you to participate in making sure that that is done and it happens. The 25 years is going to be a series of events. We are going to have a day for members of PCAU, where we will be requesting you to reach out to members within your area and share information about PCAU. We will open for this community here because we can't go everywhere, but where you are in your region before the AGM, we will send out information of 15 days, allowing you to touch base with the members who are closer to you and explaining our work and making sure that more people can join and we can build a bigger movement. I want to thank you so much and conclude by asking you to thank our chair for this session. It's always not easy to get the chair. Thank you so much, Prosi, for chairing this meeting. For all the senior people and the junior people and the members of PCAU who have been online, from me as your executive director at the secretariat, I appreciate and thank you so much and God bless you. So the update meeting is, okay, closed by the chair.
I'm the chair. Okay, before we close the update meeting, I would like members to propose the date, the topic for the next update.
We had a poll that had two things, that was looking at the National Cancer Control Plan and sickle cell. So it's to us as members to agree, should our next topic focus on sickle cell, or do we want to propose another topic? Because of time, I will please request that you share with us on the WhatsApp platform for the Palliative Care Association of Uganda. You can share on email, membership, and you get back to us with the proposed topics for our update for this year, and we'll be able to get the right people to speak to us. Thank you so much.
Thank you, Joyce. Before we close the meeting, I just want to remind us about the Sukuma Dance Cancer Fundraiser organized by the Uganda Cancer Society, which is happening on Sunday. Oh, sorry. Before we close, yes.
Good afternoon, everyone. I'm Immaculate Mbarasha. I coordinate clinical trials at the Uganda Cancer Institute. So there's just a quick one. There's a point that was raised by Dennis about patients requesting for drugs to be shipped to them or taken on bus. I request that we explain to our patients, because as Dr. Noleb mentioned, cancer is not like malaria or high blood pressure or diabetes. So whenever these patients come, I think they also complain. You may take a month before you started on treatment because of the different tests that they have to go through before they are treated. Because each patient, much as they may have a similar cancer, they are treated personally as an individual. So each patient has to go through a number of tests before they are put on treatment, because their doses are given according to their bodies. Then when they finish the cycle, when they complete a cycle, then they come back. They are not given treatment unless they have undergone blood tests. So they have to undergo blood tests so that they see how their bodies are responding to the treatment. So it is usually not possible to send drugs over the bus or anything, or through a relative. Yeah, about the pain, that one I testify. We have one of our patients on research, but she is particular about a certain type of drug that she always sends even a relative. That one, the Panadol they usually give, but it's a certain brand called Abado, and she will never buy any other from where she is in Mukono. She has to send somebody to come for the drug. Then also I agree the UCI is usually very full. They had put a strategy of putting messages on televisions and then IEC, so that as they are waiting in line, they are listening in. Then sometimes some people try to take the TVs to their homes. They steal them, but it is always full. And I agree that the information may not reach everyone. Yeah, that is something we need to work on. But as we who meet the patients, let's tell them about this. And then also, by the time someone goes to radiotherapy, they've gone through the chemotherapy, they've gone through, maybe if they need surgery, they've gone through surgery, and then they go to radiotherapy. So chemotherapy at the Uganda Cancer Institute is currently free, and it's very expensive, but they get it free of charge. Surgery is also free, unless somebody has booked as a private patient. So surgery is also usually free. So when they come to radio, that's when they have to put something. And it's true, it goes up to 1 million for some patients, but that's like a full course of the treatment. And then if they go back to, after radio, if they go back to chemo, then that is also free. So yeah, so I know it's a lot because they've always gone through a lot, but let's understand what it's all about, and then we encourage them. Of course, I know if they were told earlier as they start the chemotherapy that at some stage you will need 1 million, I think they would be ready than finishing surgery, and then you're told come with 1 million in 2 weeks. That is hectic. Yeah, so let's also understand here what goes on there so that we help them. But you're always welcome to present the patient's complaints, and then that will help us to be able to listen to them and see how to either communicate properly or communicate here so that you reach out to the patients. So that's the quick one that I wanted to chip in before we leave. Thank you so much. I'm Immaculate Mbarusha. I coordinate clinical trials at the Uganda Cancer Institute. Thank you.
Thank you so much, Immaculate, for that clarification. So I'm going to close this meeting. Do you have any questions?
Okay, thank you so much. I'm Josephine Nalvega. I work in a big hospital. We always get patients. I work in Zambia Hospital. Okay. My comment was about how she said that chemotherapy is free in Mulago. Because sometimes we get patients who have financial constraints and we send them to Mulago. But these are patients who come thinking they are going to get everything free. Yet what I know, there are certain regimens, like a doctor can combine 3. A patient comes and you have only 2 at the station, and he can't get chemotherapy in time. So what I was suggesting, we always tell them, you come with something, as we've been telling. You go with something. If the one drug is not available, at least you are able to pay. But if you tell them that it's free, they will come without any cost. Thank you.
I think the communication from UCI is encouraging us to be open to the patients that we are meeting and to be real and to do the palliative care that we are supposed to do for the patients. If it needs to consult with UCI before referring the patient, consult and provide, because this is a journey that is sometimes like somebody's walking in the dark, you know. They have already been everywhere else, and so they need a lot of support. And I think that's the information. And that goes back to what Dr. Noreb had said, that send him information. As you send information, condense it to the point of clarity, to the extent that you are sure it is really clear. You know, because after all, you're advocating for the people you serve and who you know the needs very, very well. I'm very grateful for the additionals that came at the end, because that is really big, because we are talking about the issues that affect patients, and now we had their voice come through. Thank you.
Thank you so much. I'd like us to close the meeting. I hope there are no other questions. Are there any? Okay, we have more hands online. Yes, for us, in order for us to save time, and like Mark said, we are trying to manage time as much as possible. We are going to request you to send all the other questions online or to the emails that will be shared so that we can really wrap up this. I'm going to request us to close the meeting with a closing prayer from Mrs. Lule Teopista.
I thank you, Lord, for today. I thank you, Lord, for dear life. I thank you, Lord, for our dear patients from all over the world. God, I ask you to bless each and everybody and to treat, because we know you are the best doctor to everybody of us. I put each and everybody, especially those who managed to join us, to travel peacefully to their different places. God, we thank you for everything. Amen.
Thank you, Mrs. Lule. So the meeting is adjourned. Okay, Joyce, let me hand over to Joyce for a few announcements.
Thank you so much, Chair. Thank you so much, our presenters, and thank you so much, our participants. It's just a surprise to someone who is making 70 in this very month of February. She has been a long-time member of the Palliative Care Association of Uganda. She has served beyond. She has had patients from her own family that have needed palliative care. She loves palliative care. She speaks palliative care and has always wanted to give. And this is none other than Mrs. Lule Teopista. It's her birthday, and we choose to celebrate your birthday with you. I welcome Dr. Oli, who is a volunteer with Hospice Africa Uganda, to be the one to hand over our special gift to the birthday baby. Please come, Mrs. Lule. Please come. Oh, so it's to her. You can open it. To her. Thank you so much, Dr. Oli, and thank you so much, everyone. We have some refreshments there at the near the registration desk. Please feel free to join the table. Exchange the secret. Yes, everything is there. May I request the Secretariat team to stand, please? The Secretariat team, wherever you are. That's the Secretariat team. In case you want to ask about paying your membership, renewing your membership, buying anything branded with PCAU, you have something happening within your region, your district, your hospital, please feel free to speak to any of them, and they'll be of great help. Thank you so much. Blessing, we are ready? Okay, we can walk to the table. And we wish you a happy Easter that is very close. We may not see you, but we wish you a wonderful one. As Jesus rises, may he rise with all of us. We need a group photo. We can have a few people in front here just to commemorate this update meeting of February, please. Let's just come in front here as the